The information shared on the Sky Women's Health podcast is for educational and informational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding your medical condition. Never disregard professional medical advice or delay in seeking it because of something you heard on this podcast. Reliance on any information provided by Sky Women's Health, Dr. Carolyn Moyers, or any guests featured on the podcast is solely at your own risk.
You're listening to Sky Women's Health Podcast, your evidence-based resource for women's health and wellness, exploring the holistic principles of osteopathy, integrating mind, body, and spirit, designed to empower you as your own healthcare advocate and help you live your best life. I'm your host, board-certified OBGYN, Dr. Carolyn Moyers.
Welcome back to Sky Women's Health Podcast, where we're talking all things women's health with real-world insights and evidence-based care. I'm your host, Dr. Carolyn Moyers, board-certified OBGYN, menopause certified provider, and ISHWISH fellow. Today, we're tackling, am I just tired or is this menopause tired? I came across this article, Abnormal Uterine Bleeding is Associated with Fatigue During the Menopause Transition, that was published in Menopause, the Menopause Society Medical Journal in 2025. And we know that fatigue during midlife is incredibly common. I hear this complaint all the time. It's frustrating. But a new study from the Menopause Society suggests that fatigue might not be just from hormones and hot flashes and poor sleep, but also changes in your bleeding that may be playing into this fatigue. Now, I think it's a little bit confusing because they're saying, am I tired or just menopause tired? And actually, we probably should do an episode on what's the difference between menopause and perimenopause. So menopause is defined as being 12 months without a cycle. So really, we're talking about that perimenopausal bleeding that can drive you insane because it's all over the place. It's heavier sometimes, lighter sometimes, unpredictable, and it can create a lot of grief. So let's kind of unpack that. During the menopause transition, and remember, perimenopause can last 7 to 10 years, abnormal uterine bleeding, characterized by either prolonged menstrual bleeding or heavy menstrual bleeding, occurs often. And it can be associated with fatigue. Now, in this particular article or this particular study, it's a longitudinal study. They looked at menstrual calendar data for over 2,300 participants in the study of women's health across the nation. So the SWAN study, identifying episodes of heavy menstrual bleeding or prolonged menstrual bleeding. And they looked at this over 7 annual follow-up visits. So let's talk about what they saw. So we heard hot flashes, night sweats, mood changes, creating fatigue, and it's often this silent struggle. Maybe it's not just I stayed up too late. We're talking feeling worn out even after rest, lacking energy or motivation, this persistent sense of dragging throughout the day. And here's the kicker. Midlife women are 2 to 4 times more likely to experience this fatigue, which means that it interferes with your daily life. According to this new study in menopause, heavy and prolonged bleeding during the menopause transition that we may just chalk up to being part of the process is strongly associated with this kind of fatigue. So what's going on with the period? Abnormal uterine bleeding includes heavy menstrual bleeding and prolonged menstrual bleeding. So you may say, oh yeah, I had a workup from abnormal uterine bleeding, or you may have heard your doctor use that term. Heavy menstrual bleeding is soaking through 1 or more pads or tampons every hour, needing double protection. So we're using pad, tampon, or menstrual cup and period panties, or prolonged bleeding longer than 7 days is abnormal. Prolonged menstrual bleeding includes periods that just won't stop. So they're not particularly heavy, just keep on going, bleeding most days of the month. This study found that 1 in 3 women in perimenopause had abnormal uterine bleeding. Let me say that again. 1 in 3 women going through perimenopause had abnormal uterine bleeding. That includes heavy menstrual bleeding or prolonged menstrual bleeding. Yet it often goes underreported or undertreated. But why does it matter? It can lead to iron deficiency, anemia. One of the most common treatable causes of fatigue is iron deficiency anemia. This study concluded that heavy menstrual bleeding and prolonged menstrual bleeding during the menopause transition was associated with an increased odds of experiencing 3 symptoms of fatigue, greater clinical attention to bleeding changes, and associated symptoms, including fatigue and lack of energy, is really warranted, as is education for our patients, to know the potential health consequences of excessive menstrual bleeding during that menopause transition. So let's talk about what a workup actually looks like. First, if you're experiencing heavier or longer periods, feeling exhausted, it's time to talk to your provider. And we want to look at a thorough history. How long are your periods? How often are they happening? How long heavy is the flow? Are you passing clots? Are you spotting between cycles? So getting a menstrual history is really important. You may wonder why they always ask my last menstrual period. It is a vital sign. It's important for us to know. A pelvic exam and an ultrasound may be warranted to check for fibroids, polyps, thickened endometrium. Labs are important, looking at a CBC to check on anemia, ferritin, and iron levels. I do that in almost all of my 50 and older patients, but if somebody is having heavy menstrual bleeding, we're certainly looking at this. And possibly thyroid test, insulin resistance, or hormone levels, depending on symptoms. Okay, one of the last pieces to the workup is endometrial sampling or biopsy, especially if bleeding is irregular or prolonged and there's concern about hyperplasia or cancer risk. Now, there's 2 different ways that we can sample. One is just a blind biopsy in the office where we just put a pipelle or a brush in through the cervix and take a sampling of the lining of the uterus. So I'm not actually seeing if there's anything abnormal. I'm not taking a sampling of the entire lining of the uterus. It is just, I hope we get it, right? And so this can be done in the office with some medication beforehand to help with pain, cervical block, and we add Pronox in my office. We have laughing gas to help take that edge off to address some of the anxiety and the discomfort. But that uterine cramping is really the most uncomfortable portion of the exam. Now, for some patients, we elect to do a hysteroscopy DNC with endometrial sampling. And this is particularly important if we have a higher level of concern, if the patient can't tolerate the in office procedure, or if we found something on ultrasound that made us suspect that maybe there's an endometrial polyp. The thing I love about a hysteroscopy DNC is with this procedure, we actually put a camera in through the cervix and can visualize the endometrial lining and see if there's anything abnormal going on in that uterus and get a sampling of the entire lining of the uterus. So it is oftentimes diagnostic and therapeutic because that tissue is going to go to the pathologist for further review. Okay, so what can be done? What are our treatment options, right? The good news is that there are plenty, right? We can supplement with oral or IV iron supplementation if needed to replace the iron levels, but we've got to control the bleeding. So, how do we do that? Hormonal therapies. We can use low dose birth control pills, progesterone IUDs, or traditional hormone therapy in some cases. It really depends on just what phase of life you're in and how we need to address this. Whether you've tolerated pills before in the past, whether you've had an IUD in the past, or you have an aversion to it. Like, we just have to take all of these things into consideration. And this is where shared decision making is really important. Now, tranexamic acid is one therapy that is an oral medication that is can be used for up to 5 days of heavy flow. This is non-hormonal. So some patients who are having a regular monthly cycle, but it's just heavier, this is a great option. They can use it up to 5 heavy flow days, and it can decrease the amount of bleeding during their cycle, leading to less blood loss. And then we have surgical options, which could include placing an IUD, doing the hysteroscopy DNC, and placing an IUD. doing a hysteroscopy DNC, and doing an endometrial ablation. What's the benefit there? You're thinning the lining of the uterus, kind of organizing, especially we have a lot of disordered proliferative endometrium. That's a big fancy word for essentially the lining of the uterus isn't building up and sloughing off in an organized fashion. And so you have different areas of the uterine lining that are in different phases of the cycle. And so we just go in there and kind of clean the lining of the uterus and then do the ablation, which is burning or denuding the lining of the uterus. When you compare an IUD and endometrial ablation head to head, we tend to get to the same place at 6 months and a year, having the same results in terms of satisfaction, decreased bleeding, etc. We just tend to get there quicker with an endometrial ablation versus an IUD. Now, what would be the downside? An endometrial ablation, we've got uterine scarring. It's difficult to sample the lining of the uterus any further after that. It depends also on what type of ablation's been done. So there's many things to kind of take into consideration. If we're still needing contraception at this perimenopausal phase, then placing an IUD may be an awesome option because it's going to control the bleeding and it's also going to provide that pregnancy prevention. And then, of course, a hysterectomy is also an option. It's a more extreme option, but in some complex cases, it may be warranted if we have a big, bulky fibroid uterus, or if you've tried all the things and you continue to bleed and you're just over it. There are indications for hysterectomy. And just again, any decision that you make in terms of treatment options is going to be the shared decision making. What do we think the underlying cause is? How can we best treat that? What fits best for you and your lifestyle and where you are? Some people just don't have the time to take off work to have their procedure done. And so they may choose a more non-invasive option than a hysterectomy. And usually we've got to try a couple of things before we just throw in the towel and do a hysterectomy because it's got the greatest risk involved, right? It's a major surgery. But the bottom line is you don't have to suffer. Fatigue is not just part of getting old, and heavy bleeding is just not something that we have to tough out to get to the menopausal state, which is 12 months without that cycle. If you're finding yourself exhausted and wondering why, take a closer look at your bleeding. Keep your menstrual diary. This is a critical clue to your body. It's more than just losing sleep or getting better sleep, right, to address your fatigue. It may actually be this underlying heavy bleeding, losing that iron energy, quality of life in this process. And so discuss this with your healthcare provider so that you can reclaim your energy. Thanks for joining me today. If this episode resonated with you, share it with a friend. Let's continue the conversation. You can follow me on Instagram at Dr. Carolyn Moyers. Reach out if you're ready to take the next step in your menopause journey. Until next time, be well.